So hello everyone, let us discuss about the nerves now. So first in line we have the radial nerve, but before that I hope you remember the major nerves of the upper limb include axillary nerve, muscular cutaneous nerve, radial nerve, ulnar nerve and median nerve. So these 5 nerves you should be well versed with, and if you remember regarding the axillary nerve, I have already told you that axillary nerve is supplying the deltoid muscle, right, and axillary nerve has already been discussed in the posterior cord of brachial plexus. Then we had the musculocutaneous nerve, which was the only nerve supplying the main muscles, BBC muscles in the front of the arm, if you remember, okay, the biceps brachii, brachialis and the coracobrachialis. Okay, so we had 3 muscles which were supplied by the musculocutaneous nerve, and if you remember, it was the nerve which was piercing the coracobrachialis muscle, and that's how we could identify that muscle on any kind of image or a cadaveric specimen. Next in line we discussed regarding the radial nerve. So radial nerve, as you know, radial nerve is running in the spiral groove or the radial groove. So this radial nerve is also sometimes referred to as the musculospiral nerve. So this radial nerve is also known as musculospiral nerve. Okay, now this is the nerve which is main nerve for the posterior compartment of the arm, forearm and dorsum of hand. It's the main nerve, so you need to remember, like we had the main nerve supplying the front of the arm, that was the musculocutaneous. So radial nerve is the main nerve which is for the posterior compartment, main nerve of posterior compartment of arm, forearm as well as dorsum of hand, and this has been asked in the entrance exam also and MCQs as well. Okay, the main nerve of the posterior compartment of the arm. And if you remember, radial nerve is the continuation of the posterior cord of brachial plexus. So you remember the posterior cord of brachial plexus, the root value was C5 to C8 to T1. Okay, then so if we talk about the beginning of this nerve, I will show you in 3D so you get a good orientation regarding this nerve origin and everything and its pathway. So if you remember about the course, these are certain main points which you need to remember for this nerve to frame out your answer or answer any kind of MCQ as well. So it lies posterior to the axillary artery, because if you remember, posterior cord was posterior to the axillary artery and also to the brachial artery. Okay, and this is something important. And another thing which is let me write that itself here, radial nerve is also the largest branch of brachial plexus. It is the largest branch of brachial plexus. Okay, so this is also sometimes asked in the exams. Okay, so regarding the radial nerve, now radial nerve originates from the posterior cord of brachial plexus and it enters the arm by crossing the inferior margin of the teres major muscle. So as it enters the arm, it lies posterior to the brachial artery, as we know, and it is accompanied by the profunda brachiae artery, that is a deep branch. If you remember the profunda brachiae artery, okay, let me show you in 3D. So this muscle, you remember, this was the pectoralis major muscle. Let me hide this just to bring in our view. Let me just remove the deltoid as well from here. Okay, now you can appreciate these muscles, and if we remove this one, coracobrachialis, for a time being, I will bring that back eventually. So now you can recollect these nerves, the brachial plexus, right? You know this is the median nerve because this M pattern, if you remember, this might have been taught to you already. Okay, this M pattern, okay, this is the median nerve which is formed by these two roots, and now you see this one, this nerve, this is the axillary nerve which you can see it is going behind. Okay, this is the axillary nerve. Next, this muscle, this is the teres major muscle. So I told you This radial nerve is the one which is entering the arm by crossing the inferior margin of the teres major. So now you can see there is a nerve which is crossing the inferior margin. This is the radial nerve. Okay. So radial nerve, as it enters the arm, it lies posterior to the brachial artery. Okay, that is also understandable. This is the axillary artery which continues as brachial artery in the arm. You know, arm name is brachium. Okay, so just behind this is this radial nerve. Okay, so this radial nerve is accompanied by this deep branch, that is the profunda brachial artery, and radial nerve enters the posterior compartment of the arm by passing through this triangular interval. Okay, so this is the radial groove and its contents, if you know, right? We have already discussed that previously in the intermuscular scapular spaces. Now, as the radial nerve passes diagonally from medial to lateral, okay, this passes from medial to lateral, ultimately radial will come lateral, okay, through the posterior compartment. So it lies in the radial groove directly on the bone, as you can see. Okay, and on the lateral side of the arm, it passes anterior through the lateral intermuscular septum and enters the anterior compartment, where it lies between the brachialis muscle and a muscle of the posterior compartment of the forearm, that is brachioradialis. So now let me show you this part. So now this is the brachialis muscle. Okay, and we said this radial nerve is coming on the lateral aspect. Okay, so let me show that to you, just hold on. This is the radial nerve. Okay, so this radial nerve from the top, if I just show you in that manner, just hold on, if I fade others, maybe you can see. So radial nerve is having this kind of course, it is running through the radial groove, maybe you can see in faint shadow, right? So this is running through the radial groove, going behind and then coming laterally in this manner. Okay, so now you see this muscle is the brachialis muscle, front of the arm muscle, BBC, right? So behind this we can see this radial nerve, and if we go further down, okay, you can appreciate further down if you are going. Let me just add the muscles again. So this is the brachioradialis muscle. Okay, now brachioradialis muscle, it is even it is attaching on this lateral supracondylar ridge of the humerus. Okay, so the radial nerve, it enters the forearm anterior to the lateral epicondyle of the humerus, just deep to the brachioradialis muscle. So this is also an important point. If I just hide all the others to show you, if I just hide all the others apart from the radial nerve, okay, origin path, isolate origin path. Okay, can you appreciate this? It was coming from posterior cord, going behind, coming laterally, and then finally it has come anterior to the lateral epicondyle. Now anterior to the lateral epicondyle, but deep to the brachioradialis muscle. Okay, so that is the key point to remember here. So you know where to find this nerve now, okay, in any area. Then it further gives off certain muscular branches, like which includes the triceps brachii, brachioradialis, extensor carpi radialis longus. We will see those in the flow chart. Okay, so all of these muscles important. Then we have certain cutaneous branches. Okay, so now let us come back. So I hope you have got a good orientation regarding how it's originating and rotating. Okay, so now let us see this point, course. So we have understood it lies posterior to the axillary and brachial artery, passes through the lower triangular space, we have already covered previously. It runs in the spiral groove, we know that. It pierces the lateral intermuscular septum, that also we have seen, and it lies deep to the coracobrachialis as well as ECRL, that is the extensor carpi radialis longus. This point we have not seen, let me show you. Okay, so we know this was the biceps brachii. Okay, and this is the pectoralis major, hiding it. You can see this was the coracobrachialis. Now we said it is behind this coracobrachialis. So this one, this nerve is a radial nerve. Okay, so you can find this nerve deep to the coracobrachialis. That is number 1 point. Number 2 point, we said it is behind the extensor carpi radialis longus. So let me show you this. So let me ask you, just identify from all these muscles where would we expect the extensor carpi radialis longus. Number one, extensor. So we have to see from the back side, number one point. Okay, we will not see in the flexor side. Now radial, that is radialis, so we have to see on the lateral aspect. So in this manner you can trace these muscles. So you can see the thumb side. Okay, we are seeing the lateral aspect. In this you would be expecting this muscle to be the extensor carpi radialis longus. Okay, so if I just hide this muscle to show you that point, okay, so this should be the nerve which is seen here, this nerve. This is the superficial branch of the radial nerve which you can appreciate. Okay, so this is split up from the radial nerve only. So radial nerve is lying deep to the ECRL as well as coracobrachialis, but the nerve which pierces the coracobrachialis, that is different, that is a musculocutaneous nerve. Okay, so do not confuse between these. So I hope now you know the course well. Okay, this is just an understanding we have to develop in 3-dimensional view. Okay, so now coming on to this region, the axilla. Now important point is its branches. Okay, so certain branches are there for every nerve which you have to remember. Okay, so number one, here we have the branch in the axilla region, then we have branches in the spiral groove, and then we have terminal branches. Okay, so number one, that is branch to the long and medial head of triceps. So obviously posteriorly we have triceps only, anteriorly we have biceps, so we are talking about the posterior compartment of arm. So that means we know this. Then posterior cutaneous nerve of arm, medial and lateral head of triceps. Triceps has 3 heads. Okay, then to the elbow joint also. Then we have a superficial and a deep branch of radial nerve. So let me show you this diagram which you can appreciate to understand the nerves branches. Okay, so this diagram shows you the exact picture which you need to remember. Now let me highlight the most important area which you cannot afford to miss in this diagram, that is the medial head of triceps is given off the branches mostly in the axilla as well as the radial groove. So we have, see, radial nerve has to supply this. Okay, so it is supplying long head of triceps, lateral head of triceps. Initially it is arising from the posterior cord or continuation of the posterior cord, then it is giving off a posterior cutaneous nerve of arm, that is understandable, cutaneous branch, and cutaneous branches are shown in green color in this image. Okay, so now you can see these muscles. So now this long head is getting the supply in the axilla region, whereas lateral head is getting the supply in the radial groove region. So radial, question is asked, the radial nerve at the radial groove supplies which part of the triceps? So it supplies lateral head for sure, and sometimes and most commonly medial head as well. Similarly, long head and medial head, both the branches given off in the axilla region. So moving further down from the radial groove, if we go towards the lateral part of the arm, still we are in the arm, we have not crossed the elbow joint. Okay, so you can see it is giving off brachialis muscle fibers to brachialis, proprioceptive fibers, then brachioradialis which was in the front of the forearm on the lateral aspect, then you have extensor carpi radialis longus on the extensor side, on the radial side, on the lateral side. Okay, then also a small muscle Cutaneous is being supplied by this nerve. Then before it enters into the forearm, you can see it is splitting up here into the superficial and a deep branch. Superficial branch we have already seen, we have seen in 3D just now, as well as we have seen in the cubital fossa diagram. If you remember the MBBS mnemonic, the superficial branch of the radial nerve, or MBBR. Okay, so now deep branch is also known as posterior interosseous nerve. We will come back to it again. I hope this much is understandable. So radial nerve, as you can see, it is giving off some or the other cutaneous muscular branches in axilla, in arm, and now we are talking about the forearm below. Okay, so let us see. So we have certain branches of the radial nerve in various regions. Okay, so what are these branches? terminal branches, as we have seen, that is the superficial branch and the deep branch or the posterior interosseous nerve. And this is very important. These notes you can use to make and write the key points, because in exams basically you will be writing what is written here. Okay, beyond that I don't think so you will be writing in your theory exams also, and most of your MCQs in your any exam in national level exams you can solve using this information. Okay, so terminal branches, sensory supply to the dorsum of hand, posterior aspect of the lateral 3.5 fingers, very important. Eventually you will understand, it is asked in the exams. And this is except nail beds. Why? Because nail bed is being supplied by the median nerve. So that is the difference here. Okay, nail bed is being supplied by the median nerve, whereas lateral 3.5 fingers is supplied by the radial nerve. Now deep branch, very important, it pierces the supinator muscle. Okay, we will see that in a while again, and it supplies all the remaining muscles of the posterior compartment of the forearm. Okay, now we talk about the important point, that is the injuries to the radial nerve, which is most commonly asked in the examinations. Clinical integration. Number 1 point, that is injury in the axilla region. Then we will see injury in the radial groove region, that is the Saturday night palsy, classically known as Saturday night palsy. Then we will see the injury at elbow. Okay, and we also have the 4th point, that is the posterior interosseous nerve injury. Okay, so we have to study in 4 headings for the nerve injuries related to the radial nerve. Now try to understand the concepts here. You will get these notes, so you can make notes from yourself also. So injury in the axilla. So in the axilla, this region, there is an injury to the radial nerve. Okay, so now this is due to the crutch which is used. Okay, so radial nerve is damaged due to the pressure by the upper end of the crutches. Okay, so you can see this photograph, this kind of image is there, where you can see the pressure is put in the axilla region. So this is also known as crutch paralysis. Okay, so that is very important. Then we talk about the features. Now number 1 is injury is happening at what level. Number 2, it is happening due to what thing. Okay, what common thing is causing it. Number 3, what are the features, clinical signs and symptoms which will be visible in the patient if that nerve is injured at that point. So crutch palsy, this results in the loss of extension of forearm, weakness of supination. So this all is why it is all happening, because of the muscles involved in that region, because triceps is also involved in the axilla. We are talking about the axilla, so there will be flexed elbow. So extension is lost. Okay, extensor, basically extensor muscles supply is gone. We are talking about the axillary. This is the most easy injury. Okay, everything below is affected, so all the extension is gone, supination is gone, triceps involved with a beat any head, so that is flexed elbow. Number 1, easiest. Number 2, loss of extension of wrist, and fingers. So there is finger drop and there is wrist drop. So all of these features will be very easy to remember, no brainer. Then we have something which is, we have discussed, loss of sensation in the lower and lateral posterior aspect of the arm, posterior aspect of the forearm, hand, and lateral 3.5 fingers, except the nail beds which we have discussed. Now this all is happening due to the superficial branch of radial nerve. This is all importantly asked in the Viva as well as MCQs. So they will give you these features and they will ask you which nerve involvement is there. So the question answer will be superficial branch of radial nerve if they are asking specifically the 3rd point. Okay, then we come on to the tricky part, a little bit tricky, not too much, that is the injury to the radial groove. Now imagine a situation, when will such a specific injury happen? When only the radial groove is involved. So that would be the classical case where you can see this kind of person which may be sitting. So it's a direct pressure on the radial nerve by a drunkard falling asleep with his one arm over the back of the chair. So just like that, if he is falling asleep, okay, after drinking too much on a Saturday night, so Saturday night palsy, that is the name, Saturday night palsy. So specifically radial groove injury is there in the mid shaft approximately. So there will be these features related to the Saturday night palsy. So let us see what are these. Now Saturday night palsy or the injury to the radial groove, so you should be knowing which injury they are talking about. This is the mid shaft basically involvement. So now what else can happen? That is Saturday night palsy, drunkard and everything. What else? There can be mid shaft fracture of humerus. Humerus can be fractured, you know, bone can be fractured, so there will be upper end fracture, supracondylar fracture, most common I am talking about, and then mid shaft fracture, fracture of neck of humerus also. Okay. So another thing, wrong IM injection. You know, IM injection has to be given at a specific point. If that is not followed, like quacks or some staff which is new to this world, they are giving IM injection to the deltoid muscle, what would happen? This, there will be obviously nerve will be injured. How? It, if it is crossed below. So in the radial groove that injury can happen, although this is not very common. Okay, axillary nerve damage is more common in those cases of wrong IM injection in the deltoid, but this nerve can be damaged due to the bad technique. So what will happen? Now please pay attention, it is very important. You get mostly confused in this second point and third point. All the signs and symptoms which were discussed above except medial and long head of triceps which are preserved. Okay, so now pay attention, we are talking about the injury at the radial groove. So medial and long head of the triceps, the supply to them is a little bit above, so that will be spared. Okay, so if you remember, you can see this diagram, long head and medial head, the supply to this is above the radial groove. Okay, this is the radial groove, axilla. Okay, so these two will be spared, so only lateral head will be involved. Okay, so you can see this. So what will happen? There will be weakness of extension of elbow. Extension will be affected, but there will be weakness. Okay, then wrist drop will be present. We have already discussed the reasons for the wrist drop. Okay, all the extensors of the wrist and the fingers. Finger drop will be present, wrist drop, cutaneous nerve will be involved, so sensory loss will be there. Those all features will be there. Okay, what else? Then this is the second point injury. Now different color we have followed, purple color written for the third point. So I have written first, so that as you know, this is a crash course, so we are covering everything in a very short time span. Maybe you are utilizing this a night before exam, or just, you know, few days ahead of your main exam. So you have to get maximum facts in less amount of time. Probably you have already seen these videos previously from me, so it may be a revision also. So at that time this will be essential. If I keep on writing everything down, it will be difficult for you to write and learn at the same time. So just pay attention, you will get this PDF notes obviously, so you can revise. So this is injury at the elbow. Now you remember injury at the elbow, what is the nerve? Radial nerve was traveling at what point in the elbow? I have shown you in 3D. That's the reason I have 3D orientation is important. Is it the medial epicondyle? No, it's the lateral epicondyle. So lateral epicondyle fracture can be the classical case scenario where you have specific injury of radial nerve at the elbow. Now there can be entrapment neuropathy of the deep branch of radial nerve at the elbow, that can also happen. There can be sensory loss and finger drop present, okay, in this region, because beyond elbow we still have the forearm flexors, extensors, which may be affected. Okay, so there is finger drop, sensory loss. Now we said that there is entrapment neuropathy. Neuropathy means nerve involvement, entrapment means something is trapping it. Okay, so what is it? So there can be compression by the sharp fibrous band or sharp margin. Please remember this muscle name of the supinator muscle, sharp margin of the supinator muscle, which can cause this entrapment neuropathy. Okay, of what? Deep branch of radial nerve. All right, so this also known as arcade of Froese, which is a fibroepinotic proximal edge of the supinator muscle. This language was exactly asked in INI exams, AIMS exams, so some time back. So this also you can remember, this is related to this injury at the elbow. Now question is, what will happen to the patient? So patient will appear with you with complaints of loss of extension of the wrist and fingers, which we have already discussed, but without the wrist drop. So there is no wrist drop. That is the classical important point to remember. Earlier every time the wrist drop was happening, okay, but here wrist drop is not happening without wrist drop, okay, because the extensor carpi radialis longus that is spared. How come it is spared? We are talking about the injury at the elbow. See, injury at the elbow would be somewhere somewhere here at this level, okay, in this diagram. So ECRL is already being supplied in the lateral part of the arm. So you can imagine this muscle is spared, so there will not be any wrist drop. So this question has been asked in USMLE also, so you have to remember this point. There is no wrist drop, and the reason is this, we have already discussed, because it's an important wrist flexor, okay. Wrist flexors are many, but this one is a very important one. So weakness will be there, but there will be not a complete wrist drop. So you cannot say classically wrist drop is present, okay. Then other features like pain, tenderness over the extensor aspect of the forearm, okay. Next we talk about this. So same thing which we have discussed is shown in a diagrammatic manner, okay, with the sensory loss due to which all nerves will be involved. Then there will be other motor loss, okay. Okay, then we talk about the next part of this radial nerve, that is the posterior interosseous nerve. So number one thing to remember is that posterior interosseous nerve is the nerve which is a branch coming from which nerve? That is the radial nerve. So do not confuse, right now we are discussing radial nerve, but after we do median nerve, ulnar nerve and everything, so you get confused. Posterior interosseous was the branch coming from, so it is coming from the radial nerve, pin from the radial nerve. Then it's a deep branch, you can remember that way. Superficial branch was the one which was in the part of the cubital fossa, if you remember, okay, the contents of the cubital fossa, superficial branch, we could see that above. We have already discussed that was the superficial branch of radial nerve. Here we are discussing the deep branch of radial nerve. Then what are the important points regarding this? Number one, it pierces the supinator muscle. So very important muscle, supinator muscle, that is the muscle which was causing the entrapment neuropathy also, if you remember, right. So there is a supinator muscle involvement. Then there is lies between the superficial as well as deep extensor muscles. So between the extensor groups in the forearm, it is sandwiched between the two, okay. So then we have certain branches. So before the supinator, before it pierces the supinator, it gives off branches to the ECRB as well as supinator. ECRB is brevis. Earlier we had discussed that was the longus. So ECRL was by the radial nerve, main radial nerve, but ECRB brevis is by the posterior interosseous nerve, okay. Then supinator, within the supinator it supplies supinator, so it pierces supinator and it passes between supinator, easy. Then after emerging from supinator, what happens? It is supplying the extensors. Now obviously it is in the posterior compartment only, so what extensors will be involved? What will be supplied? Extensor digitorum for all the digits, extensor digiti minimi, extensor carpi ulnaris, then abductor pollicis longus for the pollex, that is thumb, and then extensor pollicis brevis, then extensor pollicis longus. So extensor pollicis longus and brevis, okay. Extensor, this is for, these three are for the pollex, these are for the digits, and this is for the index finger specifically, extensor indicis, okay. So having understood this, now let us talk about this image, that is the image showing the supply by the deep branch. So radial nerve was splitting into superficial branch and a deep branch. Deep branch was given the name, that is the posterior interosseous nerve. Now we are talking about the region that is the forearm below. So ECRB, supinator, all these muscles which we have just now discussed are written here, same things in the diagrammatic manner, and a branch to the wrist joint is also given here. And there is a pseudoganglion, this has been sometimes asked in the MCQs, pseudoganglion which is present in the just before it supplies to the wrist joint, okay. So that is also the part of the posterior interosseous nerve, okay, which is a branch coming from the radial nerve. Then we talk about the nerve injuries continued, okay. So fourth injury is the pin injury, that is a posterior interosseous nerve injury. It is due to the radial head injury, specifically head of the radius involved. or there can be surgical excision of the radial head, or there can be supinator syndrome, that we have discussed. So there can be pin injury. Now imagine what will be the features of the pin injury. So there will be triceps which will be spared because triceps were supplied above, so there will be no problem in elbow extension. We are talking about below elbow, no problem. No wrist drop. Why? Because ECRL was already supplied above, so it will be spared, no problem. We are talking about the PIN only, okay, posterior trochleus nerve. Then finger drop will be present. Why so? Because there is extensor digitorum which is supplied by the posterior trochleus nerve. This is involved. Then we have the superficial branch which is spared. We are talking about the PIN injury only, okay. So there will be no sensory loss. Superficial was supplying the sensations, okay, sensory loss. Now high yield points from this nerve before we jump to the next, that is the few points to remember. Damage to the radial nerve in the spiral groove spares the long head of triceps, okay, that is important. In the radial groove we are talking about, spiral groove, okay. Then wrist drop is due to the injury of the radial nerve, okay. The thumb action, because these questions are directly asked, wrist drop is due to the injury by the radial nerve, injury to the radial nerve. Then thumb action is totally affected in the radial nerve trauma, that is the extension. So we have already seen the other actions, okay, by which is the thumb is the only digit which can be checked for the nerve injuries of all three: radial nerve, median nerve, ulnar nerve, okay. So radial nerve innervates the brachioradialis, extensor carpi radialis longus before giving off the deeper branches. That also we have seen in 3D, okay. So I hope it is clear to you. Next we come on to the median nerve, okay.